Thank you so much, and thank you for the introduction and the opportunity to be here. I'm very glad to see that there's a forum for us actually to talk about stomach cancer together, and I'm happy to kind of start with speaking a little bit about the role of radiation therapy in the treatment of stomach cancer. So I am a radiation oncologist. I see patients and treat patients at the University of Washington Medical Center, as well as the Seattle Cancer Care Alliance Proton Center as well. If we advance on to the next slide, I'll start by talking a little bit about what is radiation therapy, because I think a lot of people are not necessarily familiar with it. And I think a lot of people also find the word radiation to be terrifying. So a little bit about what is radiation therapy, and then when might we use radiation therapy in the treatment of stomach cancer. And so in the United States, most radiation treatments are given by these machines called linear accelerators. And so the radiation is being generated by this machine, and there's actually no radioactive material anywhere. There's only radiation when the machine is on. So as the picture demonstrates, there's the machine, and the patient is basically lying flat on their back on this table, and then the machine can move around you, and then there are going to be people called radiation therapists who are going to be walking around operating the machine around you as well. But the treatment is painless. It should feel a lot like getting an X-ray or a CT scan. You don't feel the radiation, you don't see the radiation. It doesn't hurt or burn or anything like that. You won't even necessarily know when it's on, other than we will tell you, hey, we're going to turn the machine on. So it's basically like getting a scan, but of course we're giving a much higher dose of radiation focused on a very specific area. And so decades ago, when radiation therapy first kind of came into being, it was pretty crude. So the image on the left here is basically an X-ray of someone's upper abdomen region. And what this patient did was they had to drink that oral contrast, which some of you may be familiar with, where you drink this liquid and it shows up bright on a scan. And so that blob that the yellow arrow is pointing to is basically the contrast in the stomach. And so the goal of radiation therapy has always been, like any other cancer therapy, you want to kill the cancer cells and you don't want to damage too much of the normal non-cancer cells. And so the treatments decades ago started with basically we would take an X-ray, we would try to figure out where the organ is, and we would draw a pretty large kind of radiation field. So the white lines on that X-ray there are basically what a typical radiation field look like for stomach cancer, because we are trying to cover the stomach, which is the area containing that white contrast that the patient drank. And we also want to make sure we're covering the relevant lymph nodes in the area, since the cancer can spread to lymph nodes. And so, as you can imagine, the radiation treatment is pretty tough, since you're treating a pretty big area with radiation field. So as technology has advanced through the years, now we have things like CT scans, for example. So you can actually do a CT scan and be able to see the stomach on the scan. So on this CT scan image, I think this is the stomach that has, again, that oral contrast that the patient drank. And we can actually now see where the stomach is and try to target the radiation around the stomach and try to limit the radiation dose to other organs in the area like the liver or the spleen. So this is basically showing the red line is the area that we're trying to target because we want to treat the stomach, plus some of the surrounding lymph nodes. And then the green line is about 95% of the radiation dose that we're trying to give. And so that's fairly conformal around the tumor. But there is low dose kind of radiation. This is about 50% of the intended dose to the bigger area. So we're getting better at trying to narrow the radiation to really just what we're trying to target, which is the cancer. If you ever do read about radiation treatments, you may come across words like radiosurgery or stereotactic radiation or SABR or SBRT. There are a lot of acronyms for it. It's basically the next step in the evolution of radiation treatment, where you're essentially using, a lot of radiation beams. So this, for example, is looking at a tumor that's in the lung, and you're basically looking at a lot of different radiation beams coming from all different directions that are all converging on the tumor, so that hopefully we're getting the very high dose to the cancer, but a much lower dose of radiation to the normal tissues and organs that are around the cancer. So what might that look like on a CT scan, for example? So this is a CT scan through the chest, and you got the lungs on both sides, and that little red circle is showing that there's a cancer in the lungs. So the most common scenario is that the cancer started elsewhere and has spread to the lungs, so now you have a lung metastasis from the cancer. And for clinical reasons, we're deciding to treat that with a radiation treatment. And so what happens is we use a lot of different beams of radiation coming from all different directions, so that these are different isodose lines, meaning they represent different doses of radiation, and you're getting a very high dose of radiation to the tumor, but hopefully a much lower dose. So the teal line kind of on the outset is about 10% of the radiation dose that the tumor is getting. So we're getting better at getting a high dose of radiation to the cancer and much lower dose to the good tissues that we want to save around the cancer. We can do this certainly to lung tumors, but tumors in other parts of the body as well. Another area that we are often asked to treat with radiation are tumors that are in the spine, because you basically have your kind of vertebral body, the bones around your vertebral body, and then the spinal cord is in a small canal that's going through it. So if you have a tumor that's growing in the bone around the spinal cord, there's not a lot of room there, and a very small tumor can start to press against the nerves and cause neurologic problems. So we often have to give radiation there, and often there's very critical organs like the heart or the lungs right around it, and we want to be very sophisticated about how we give radiation without causing too much damage to the surrounding areas. Here in Seattle, we also have access to a different kind of radiation technology called proton radiation. Basically, most of the radiation that we give in this country are something called X-ray radiation, or photon radiation, meaning a photon is basically light, like we're seeing right now, but of course we use a much higher energy photon to treat cancer. But proton radiation is a different type of radiation, and the major difference is that regular radiation goes into the body and travels out the other side, whereas proton radiation goes into the body and stops after a certain distance. So the most common kind of poster example that we give for proton radiation are in treating certain kinds of brain tumors, especially common in children, that require us to not only give radiation to the brain, but also to the entire spine. And so you can imagine that if you were to do that, then when the radiation exits out the front, you're going to be hitting a lot of critical organs like the heart, or parts of the lungs, or the liver, or the stomach, for example. And so what proton radiation allows us to do is that we can treat the brain and the spine and spare radiation to all the good organs that are in the front that we're trying to avoid treating. And so what does that mean for the scenario of stomach cancer, for example? The more common situation is in the treatment of what we call gastroesophageal junction tumors. So basically, our mouth connects to the esophagus, which connects to the stomach. And the junction of where the stomach and the esophagus meet is unfortunately a common place to develop tumors. And in that scenario, we will often give radiation treatment prior to surgery to remove the cancer. And so in that scenario, when you give the kind of regular radiation treatment, if we imagine the red blob is the tumor that we're trying to aim at, when you give regular radiation, we've gotten pretty good at really only giving the high dose radiation to the tumor, but there's that kind of lower dose radiation all around because you have beams coming in from a lot of different directions. With proton radiation, we typically just use radiation beam that comes in from the back so that hopefully we're covering the tumor and we're staying below what's safe to give to the spine so there's no side effects or damage there, but we're avoiding giving radiation to other organs in the area like the liver or the heart or the lungs. So radiation therapy is getting more sophisticated, although there's always room for a lot more improvement. When you're talking about treating a cancer organ like the stomach, as you imagine, your stomach moves on a minute-to-minute, day-by-day basis as you eat, as you drink something, and as you breathe, because it's kind of close to where your diaphragm is. And so if we're going to try to be very focused with the radiation treatment, we have to make sure we're not missing the tumor as it's moving. And so we have the ability now to do what we call 4D scans, which means that we actually do a very slow CT scan so we can watch your organs move as you breathe to make sure that we're covering, the tumor that we need to treat, even as you're taking, kind of breathing in and out when you're getting your radiation treatment. We also have the ability to do a daily CT scan, very low dose CT scan, while we're treating a patient to make sure that we can see the stomach, that it's lined up properly to what we're aiming at before we turn on the radiation beam. So this scan up here, for example, is an example of what we call a cone beam scan that we may do on a daily basis as we're treating patients. And this white outline is where the stomach position was when we planned the radiation treatment. But as you can see on this particular day, it has shifted in position slightly, so we can adjust the radiation field to make sure that we're still on target with what we need to treat. And then this is an example of a kind of what a patient's breathing pattern might look like as you're kind of breathing in and out. And the yellow line is meant to be on top of the liver, but you can tell that as you're breathing, the liver is moving, and so is the diaphragm, and that means the stomach is moving a little bit as well. So as we're trying to be precise, we are also developing more technology to make sure that we're not missing the tumor as we're being more precise with the radiation treatment. And so that's kind of a very brief overview of what radiation is all about and what can we do. So when do we typically give radiation treatment for stomach cancer? There are multiple times where we might do this. Sometimes we might give radiation treatment before surgery to remove the cancer to help improve the odds of curing the cancer. We might do this after surgery to help improve the odds of curing the cancer. There are some patients who may not be able to have surgery, and so as an alternative, radiation can sometimes be given, although this is pretty unusual because we have excellent surgeons who are able to do the operation safely. And even in patients who have metastatic cancer, stage 4 cancer that's already spread elsewhere, and we don't think cure is possible, we can still sometimes use radiation to help control symptoms from the cancer to improve quality of life. And the most common symptoms that we use radiation to help are either obstruction, you have a tumor in the stomach so you're having trouble eating and we're trying to shrink it with the radiation, or there's bleeding from the tumor, or there's pain from the tumor. So those are the most common scenarios. So I don't want to go too intense into clinical trial data, since I think this is meant more for a patient session, but I'll go over some of the clinical trials that informed why do we treat stomach cancer the way we do, since everything that we do in medicine, we would like it to be evidence-based. We would like there to be evidence that it's going to help more than it's going to hurt a patient when we do this. And so the most common scenario where we give radiation treatment prior to surgery is for tumors at that gastroesophagus junction that we talked about earlier, because that's a more challenging area to remove surgically than when the tumor is entirely in the stomach itself. And so the reason we do this is because there were multiple clinical trials done, with this being the largest one, where they looked at chemotherapy and radiation together prior to surgery versus surgery alone for cancer that's either in the esophagus or in the esophagus gastric junction. And so this is a randomized study, meaning that hundreds of patients volunteered to be on the study, and a computer assigned them to either just go straight to surgery or to have that chemotherapy and radiation and then go to surgery. And these are survival curves, meaning that on the x-axis, this is kind of month or years out from treatment, and on the y-axis it's how many patients are still alive at that time point. And the ideal goal would be to have this line be perfectly flat at 100%. Everyone's cured. But as you can see, having chemotherapy and radiation prior to surgery for the appropriately selected cancers helps to improve the odds of being cured compared to doing surgery alone. So for gastroesophagus junction tumors, we will routinely give radiation and chemotherapy prior to surgery to improve the cure rate. The typical treatment that we give is usually chemotherapy once a week with 2 drugs called carboplatin and paclitaxel. And then we give radiation every day for about 5 to 6 weeks, and then allow patients about 6 to 10 weeks to recover, and then on to surgery to have their cancer removed. They have tried to look at doing chemoradiation specifically for stomach tumors, although there's not as much data on that. And so right now, there's actually an ongoing randomized trial called Top Gear, where they're basically doing something quite similar, but only looking at patients who have stomach cancer, meaning taking patients that have kind of cancer of the stomach, and they're randomized to either chemotherapy and then on to surgery to have their stomach cancer removed and more chemo, or chemotherapy plus radiation treatment. And the goal of this is to look at which one would be better, which one is going to be better at curing patients, chemotherapy by itself or chemotherapy and radiation before surgery. And so what is another time that we might use radiation in stomach cancer treatment? For a long time, we used to routinely give radiation treatment after surgery for stomach cancer. And the reason was because of this clinical trial that was done called Intergroup 0116. You don't have to remember that. But what they did was they basically looked at patients that had the appropriate type of stomach cancer, and they were randomized to, they had the surgery and then no more treatments, or they received chemotherapy and radiation afterwards. And again, when you look at the survival curve, the addition of chemotherapy and radiation afterwards seemed to help. The biggest criticism of this clinical trial has been you were comparing surgery alone to surgery plus chemo and radiation, so you don't know that maybe radiation was what helped. Maybe it was the chemo that did all the hard work and the heavy lifting. And so there have been a couple of clinical trials that then have directly compared that, meaning taking patients with stomach cancer, they have surgery, and then they either get chemo or chemotherapy and radiation. And this trial is more recent. They have a nice acronym called ARTIST. And what they showed was that on the survival curve, you probably have a hard time picking out which one is better because they're about the same. So meaning that for this trial, at least, they seem to show that there's no need for radiation after surgery for stomach cancer if you're getting chemotherapy. That chemotherapy seems to be as good as chemotherapy plus radiation. On the right side, the figure is looking at what they call subgroup analysis, meaning we are aware that not every patient with stomach cancer is the same. You're all individuals with particular cancer characteristics. So can we more finely divide the patients into different characteristics and groups, like how well is the performance status, what kind of surgery was had, whether there were any cancer in the lymph nodes, how many lymph nodes were taken and involved, what stage was the cancer, et cetera, and trying to see was there a particular subgroup of patients that benefited. And the only subgroup that seemed to potentially benefit from radiation are patients who had lymph nodes that were involved at the time. And so they're now testing this similar concept of chemo versus chemoradiation in a trial called ARTIST-2, but limiting it to people who had lymph nodes that had cancer in it at the time of surgery. And so this is a question that remains to be answered. This is another trial called CRITICS study, another nice acronym, looking at patients that initially had stomach cancer diagnosis. They all meant to have surgery, and they were supposed to receive either after surgery chemotherapy or chemoradiation. And again, they did not seem to show that the addition of radiation to chemotherapy had a benefit. One thing that became very apparent from this trial was that only about 60% of the patients who go on the study are able to complete the full course of prescribed treatment, meaning chemo, surgery, and then more chemotherapy, because it is a tough treatment regimen. And so for example, over almost 400 patients were initially assigned to each arm, and ultimately per arm, less than 200 patients were able to actually complete the full course of therapy. So it's definitely a reminder that the treatments we're giving, even though they're helping, they're still very tough treatments, and we need to be better at coming up with treatments that are better tolerated for our patients. And so when do we currently give radiation after surgery? So this is the NCCN guidelines, which if you're not familiar with it, it's a national expert, national expert consortium of big comprehensive cancer centers across the country, and you have a lot of experts who sit down and say, hey, this is what we think is state of the art for treating various kinds of cancers. And so their recommendation is that the main time to give radiation after surgery for stomach cancer is really if they were not able to remove all the cancer at the time of surgery. So meaning there were a few cancer cells left behind, or, or even maybe a visible tumor. It doesn't happen too often in the hands of an excellent surgeon, but it does happen sometimes unexpectedly. And so that's when we would most likely want to give radiation treatment after to clean up the cancer cells that may be left behind. And so another scenario where we give radiation for stomach cancer treatment is when the cancer is not able to be removed by surgery, meaning either it's pretty advanced, so we don't think the surgery could remove all the cancer, or if the patient is perhaps not healthy enough to undergo surgery. Again, I think in the hands of our surgeons, this doesn't happen too often, but that is definitely a scenario where we may give radiation and chemotherapy treatment. The reason we don't like to give radiation in the place of surgery is that when we did clinical trials that looked at chemotherapy and radiation prior to surgery, that gives us a chance to look at the tumor at the time of surgery. And what we find is that when you give the chemotherapy and radiation, the cancer will disappear, meaning there's no more cancer cells at the time of surgery, but it only happens about 26% of the time. So meaning that probably close to 75% of the time, if we give chemotherapy and radiation, there's still going to be cancer cells left behind at the end of that treatment. So if possible, we prefer to remove that surgically when feasible. And so I also mentioned that another kind of area where we give radiation treatment for stomach cancer is really in palliative radiation, meaning we don't believe that we can help cure the cancer, but the goal of this is to improve quality of life by alleviating symptoms. And so when we do this, the radiation dose is often lower because we're trying to cause less side effects. And because of that, the radiation treatment course is also often shorter. It's usually 1 week or 2 weeks rather than a full 5 to 6 week course of treatment. And again, obstruction, bleeding, and pain are the most common treatments that symptoms that we try to palliate. So for example, this is a study that had over 100 patients that had advanced gastric cancer, and they looked at giving palliative radiation treatment to look at how good was the radiation at alleviating the symptoms that we were trying to treat. And radiation is usually pretty good at stopping bleeding. So when you give the radiation for bleeding, about 81% of the time, the bleeding will stop, and it will stop for usually at least about 3 months. We also are okay at treating pain, meaning about half of the patients will experience improved pain relief, and it will last for most of their remaining lifespan. We're also about 50% at improving obstruction, meaning patients feel like it's a little bit easier to eat and get food down, and again, lasting for several months from the treatment. So I think in summary, for radiation treatment, the role of radiation treatment in stomach cancer is still evolving. There's still multiple ongoing clinical trials that are trying to define when and who are the right patients that would benefit from having radiation treatment. And radiation treatment can have a role in both helping to cure the stomach cancer as well as improving quality of life after treatment. And on a more personal note, as a plug for radiation oncologists, we always say it's not just about having the technology, it's also about knowing how to use the technology. So with that, I want to thank you for your time today and for the opportunity to speak to you. I'm happy to take questions during the panel session.